Okay, so now, in the interest of time, we will proceed with the second lecture for urothelial cancer. Um, I would just like to say at this point that if there are any questions, kindly type them in the Q&A box, and our speakers would be more than willing to address these questions. So our second lecture is entitled The New Era of Immuno-Oncology for Invasive Urothelial Cancer, Muscle-Invasive to Metastatic Disease. And it will be given by Dr. John Querol, who is a medical oncologist. He's a consultant in the Veterans Memorial Medical Center, the Medical City, and Diliman Doctors Hospital. And he is also the training officer of the Medical Oncology Fellowship Program in Veterans Memorial Medical Center. So if we can put up the lecture of Dr. Querol.
Good morning, everyone. I would like to thank the Philippine Urological Association and its organizing committee for a kind invitation. I'm going to discuss the role of immunotherapy for advanced urothelial cancer, for muscle-invasive up to metastatic disease. Our course outline for this morning, I'm going to talk about the role of immunotherapy for treatment of advanced urothelial cancers. Of course, we're going to discuss the different clinical trials using your immunotherapy in muscle-invasive bladder cancer. We're going to review the standard of care for advanced urothelial cancer, especially the first and second line treatment. And of course, we're going to discuss what's in store for us, the future directions of immunotherapy in urothelial cancers. So if you look at the evolution of the systemic therapy for advanced urothelial cancers, since 1989, we've been using your chemotherapy, your MVAC, your paclitaxel, docetaxel, and the less toxic agents like your gemcitabine and cisplatin. But by the year 2016, we have a lot of research ongoing and results for the use of your immunotherapy for advanced urothelial cancers. So for the past 5 years, your immunotherapy has a lot of encouraging results for the treatment of our bladder cancer using in the neoadjuvant setting and of course to the metastatic setting of urothelial cancers. So let's review a little bit of the basic concept of your immunotherapy. What makes cancer develop? What makes cancer progress? Okay. And it shows that the immune system has a major role not only in clearing cancer, but also allowing cancer to progress and develop. So these are basic interaction of our immune cells to the tumor cells. We have to remember the concept of immunoediting, or what we call the 3 E's: elimination, equilibrium, and escape. Elimination meaning if the immune system, our immune cells, targets or interacts with the tumor cells, if it's still low volume, then the immune cells can eradicate these tumor cells. We call it elimination. And the concept of equilibrium, when the immune cells control the tumor growth, usually it stabilizes the disease in our body. And of course, the concept of escape or evasion, wherein there's a continuous tumor growth, there's a genetic instability, and usually the tumor cells overwhelm our immune cells. So just illustrating to you that the immune evasion of cancer, usually if you have a progressive metastatic cancer, it represents a failure of our immune system or immune surveillance. So in our immune system, there are what we call the activators and inhibitors of our immune system. Okay? The activators, this triggers the T cell to control any tumor cells. And of course, the inhibitory part of our immune system, this one controls the activity of the T cells to prevent any wild action of our immune system. Meaning to say, for those patients who have, if we don't have this inhibitory action of our immune cells or the markers, then you will develop a lot of autoimmune disease processes. So remember this one, the focus of our topic is these inhibitory factors of our immune system, the CTLA4, your PDL1, PD1, and of course the B7.1. So what are the principles of cancer immunotherapy? Our immune response to cancer has both, as I've said, stimulatory and inhibitory factors. These inhibitory immune checkpoints includes those, as I've said, CTLA4, programmed death 1, and programmed death ligand 1. Okay, these inhibitory immune checkpoints limit the immune response to prevent autoimmune disease. These inhibitory immune checkpoints often upregulated in tumor and immune cells invading tumor cells. It also results in inhibition of the T cell immune response, therefore allowing tumor to easily hide and undetected by the immune cells. So researchers develop these immune checkpoint inhibitors. These are antibodies that block immune checkpoints, again, to enhance the T cell and other immune cells to function fully. An example of our checkpoint inhibitors are your pembrolizumab, nivolumab. These are programmed death 1 inhibitors. Your atezolizumab, avelumab, and your durvalumab, these are PDL1, programmed death ligand 1 inhibitors. And of course, your ipilimumab, the CTLA4 inhibitors. So this is an illustration for us to further understand the role of the PD1 and PDL1 activity. Okay, there's a suppression of the T cell response. If there's a tumor, then naturally the T cell will react on the tumor and controls the tumor or eradicate the tumor. However, these tumor cells produce the PDL1, and there's an interaction with the PDL1, the PD1, and this one is an inhibitory part of our immune cells, thereby inactivating the T cells. So the T cell will not recognize the tumor cells, and the tumor cells will continuously grow. So what research developed, they developed the PD1 inhibitor and PDL1 inhibitors, just taking the brakes off. So if you negate this interaction, the PDL1, the PD1, then you can activate again your T cell and recognize these tumor cells and control the growth or overpopulation of your tumor cells. So these are very important factors, the PD1 inhibitor and PDL1 inhibitors. So this PDL1 checkpoint inhibitor targets the PDL1 and restore the anti-tumor T cell activity of our immune system. Now let's go to the clinical part of this, the immunotherapy in muscle-invasive bladder cancer, specifically in the setup of your neoadjuvant and adjuvant setting. So we know that despite improvements of the pathologic complete response and survival rates with the use of your neoadjuvant chemotherapy, patients still develop recurrence. Usually the standard of care for now for muscle-invasive bladder cancer is the use of neoadjuvant chemotherapy. Okay? There's a residual high-risk disease, usually after giving neoadjuvant chemo and the patient underwent cystectomy, around 50% will present more than pathologic T2. And this represents a poor prognostic factor for our patients. So recently, we have a lot of clinical trials using your multiple checkpoint inhibitors, again, to improve survival of this subset of our patients. So these are the two clinical trials. These are phase 2 trials. The use of neoadjuvant checkpoint inhibitor, PD-1, PD-L1 for the muscle-invasive bladder cancer. We have the Abacus study and the PURE-01. The Abacus study using your PD-L1 atezolizumab, and then PURE-1 using your PD-1, the pembro. Give neoadjuvant immunotherapy, and then the patient will undergo cystectomy. If you look at the eligibility criteria for these phase 2 trials, for the Abacus, they included T2 to T3B, same thing with the pembro T2, T3B. However, in Abacus, node positive are not allowed, but they allowed the T4B. In contrast with your PURE-01, N1 allowed, but T4B not allowed. Of course, the primary endpoint for these two phase 2 trials is pathologic complete response after surgery. For Abacus, they accrued like around 74 patients, 67 underwent cystectomy, and 68 are accessible for primary endpoint. For the PURE-01, 43 patients accrued, 43 patients underwent cystectomy, and 43 patients are accessible for primary endpoint. Okay, if you look at the primary endpoint of this phase 2 trial, the PCR rate, it looks like the PD-1, the immunotherapy, is similar to the cisplatin-based neoadjuvant chemotherapy. Look at this. And if you look into the specific results of the PURE-01, the PCR rate for pembro is around 40%. For your atezolizumab, it's around 29%. No? Again, if you compare it with your standard of care GemCis, which is around 15 to 32% PCR rate, and for MVAC, it's around 26 to 43%. Oh, these are encouraging results, no? But we need long-term outcomes before we use it clinically. And one question, no, that they have to address giving your immunotherapy for neoadjuvant muscle-invasive bladder cancer is, can we predict PCR? Okay. For the PURE-01, they noticed that for patients who have high score of your PD-L1 based on the immunohistochemistry, these are markers, no? Programmed death ligand 1. You give the tissue, and then they're going to perform immunohistochemistry. If you have a score of more than 20% and you have genomic alteration, then you can go, you have a result of 90% PCR rate. No? That's very high. And for the Abacus study, okay, again, it showed that if you have a patient with high PD-L1 scoring, you can achieve PCR rate of around 40% compared with the PD-L1 negative patients, which it's around 16%. So right now, we have a lot of ongoing clinical trials using your immunotherapy as neoadjuvant chemotherapy. These are phase 2, phase 3 trials. No? So I would like to share a case in our institution, Veterans Memorial Medical Center, wherein we're a part of this immunotherapy trial under Astra using immunochemotherapy for muscle-invasive bladder cancer. So we have a 64-year-old male smoker diagnosed with invasive urothelial carcinoma around March 2019. And the CT scan showed a 3.5 enhancing soft tissue mass lesion at the left anterolateral wall of the bladder. And we had a CT scan of this, and the stage of this patient is stage 2, clinically T2B and 0M0, status post TURBT. The patient enrolled in our clinical trial using your immunotherapy durvalumab plus chemotherapy gemcitabine and cisplatin. This is the Niagara study. Okay, the eligibility or the inclusion criteria: resectable locally advanced muscle-invasive bladder cancer, T2 to T4, ECOG performance status 0 to 1, randomized into arm 1, durvalumab immunotherapy plus your GemCis or chemotherapy for 4 cycles versus GemCis alone. And then after 4 cycles, we're going to perform cystectomy. The primary endpoint for this one, again, PCR, complete pathologic response. So the patient underwent 4 cycles of the chemoimmunotherapy, and the repeat scan showed a regression of your soft tissue mass. You can see almost flattening of the soft tissue mass lesion at the left anterior lateral wall of the bladder. And if you compare July 2019 to November 2019, you can see there's a regression of the bladder mass. So the patient referred back to urology, our team, headed by Dr. Alpas. They performed radical cystoprostatectomy with iliac conduit, and we got a very good results. Patient have a complete pathologic response. So the patient was given continuation of immunotherapy using durvalumab every 28 days. And after 4 cycles of the maintenance immunotherapy, CT scan showed no target lesions or still clear of the disease. So if you look at the NCCN guidelines right now, 2020, for muscle-invasive bladder cancer, the standard of care is still use of your chemotherapy, basic chemotherapy, and immunotherapy is not yet included in the neoadjuvant. I'm saying not yet, but maybe given those clinical trials that we see with encouraging results, probably they're going to incorporate immunotherapy in neoadjuvant setting. So right now, let's shift from muscle-invasive bladder CA to a metastatic urothelial cancer. Of course, the role of our immunotherapy using PD-1 and PD-L1. So these are the clinical trials, using immunotherapy as first line for metastatic urothelial cancers. The use of atezolizumab, pembro, and if you can see, most of them approved since April 2017. So focusing on this IMvigor 210, the use of your atezolizumab as first-line treatment for cisplatin-ineligible patients. You can see there's an overall response rate of around 24%. The median overall survival is around 16 months. And look at this, 58% alive at 12 months. Very good results. And the Keynote 052, using your PD-1 or pembrolizumab as first line, okay? The results updated last year, 2019. They accrued around 370 patients, okay? Objective response around 30%. Median overall survival is around 11.3 months. And again, almost 50% alive at 12 months. Again, a very good result. And this one, okay, they try to look for patients who have PD-L1 positive score of more than 10, meaning to say high score of your PD-L1. It showed that the median overall survival is around 19 months versus 9.7 months, those who are PD-L1 low. And if you look at the overall survival, the 2-year overall survival of these patients, they have 47% for patients who have high PD-L1 scoring. Again, these are encouraging results because patients are metastatic setting, okay? And we don't see this one, we don't see these results with the use of our standard chemotherapy, okay? So use of PD-L1 expression to select therapy for cisplatin ineligible, you have to be careful. So for those patients who are PD-L1 low, then recommendation is still you give chemotherapy standard of care. But for those patients who have high, then you have an option to give your single agent immunotherapy. They have very good response rates. So trying to to compare the response rates of the first-line therapy for metastatic urothelial carcinoma. For cisplatin-eligible patients, the use of your MVAP or GemCis, you can go as high as around 50 to 60% response rates. But for those patients who are cisplatin ineligible, so we know for the fact that patients with urothelial cancers usually present with obstructive uropathy, and usually they have very poor kidney function. So this is important for us, the cisplatin ineligible patients. Then we have a choice of giving GemCarb, less toxic with the cisplatin. And of course, we have options of giving pembrolizumab, especially if the patient is PD-L1 positive or high, then you can have a good response rate around 60% comparable with your MPAP or GemCis. So cisplatin-based chemotherapy in urothelial cancers yields durable response. This is the original tail of the curve. This is standard of care. No? For cisplatin-eligible patients using your GemCis or your MVAC, you can have median overall survival of around 14 to 15 months. And for cisplatin-ineligible, then you can have a median overall survival of around 9 months. So what we know right now for first-line therapy for metastatic urothelial cancer, that the chemotherapy is very active in this subset of patients. Cisplatin-eligible patients should get cisplatin. And we should consider first-line immunotherapy, atezo or pembro in cisplatin-ineligible patients, especially if they have high PD-L1 scoring based on the immunohistochemistry. Now let's going to shift to the second-line treatment. These are patients who progressed after giving your first-line treatment. We have the Keynote 045 and the IMvigor 211. Your Keynote 045 using your pembrolizumab, okay, compared with our versus your standard of care of giving paclitaxel, single-agent docetaxel, or vinflunine. For the IMvigor 211, you're giving atezolizumab or PD-L1 versus, again, the standard of care, single-agent chemotherapy. And the primary endpoint for this one is overall survival and progression-free survival. The pembro, a second-line therapy for advanced urothelial cancer carcinoma, published in the New England Journal of Medicine 2017. And they accrued around 500 patients, okay, randomized 1:1, pembro, one arm. The other arm is using single-agent pacli, doce, or vinflunine. And the results, if you look at the results of the Keynote 045, overall survival, there's a separation of curve to the advantage of giving your immunotherapy, 10.3 months versus 7.4 months. If you look at the subset of patients who have very high or increased PD-L1 status scoring, then you can achieve a wider separation of curve, 8 months versus 5.2 months. If you look at the IMvigor 211 study, again, patients second line treatment, those patients who progressed after the first line of chemotherapy, they are randomized into atezo versus standard of care vinflunine, docetaxel, or paclitaxel. The results almost similar with your pembrolizumab. You can see the separation of curve, again, to the advantage of using your immunotherapy atezo versus chemotherapy. So we know that in second line, first line, immunotherapy has very encouraging results, maybe better than chemotherapy. But the question is, where do we go from here? No? Okay. These are the different clinical trials ongoing right now. Hopefully in the next 3 to 5 years, we have good results. Again, for the interest of our urologists, no? The non-muscle invasive clinical trials, Keynote 057, they're trying to incorporate immunotherapy in BCG unresponsive non-muscle invasive bladder cancer. And they're trying to incorporate also immunotherapy plus minus BCG in high risk non-muscle invasive bladder cancer. These are very interesting clinical trials, and that we'll see, of course. Of course, the muscle invasive, wherein they're trying to incorporate immunotherapy for as neoadjuvant. Okay, we have a lot of clinical trials ongoing. We have to wait for their results. And for the treatment naive metastatic, first line or second line, they're trying to fine tune the use of your immunotherapy using double immunotherapy or combination with chemotherapy. I think interesting for us is the use of your immunotherapy as maintenance treatment for locally advanced metastatic urothelial cancer. So in lung cancer, stage 4, there's the concept of giving maintenance treatment. No? The patient given initially of chemotherapy and the patient is stable, rather than give them a few more sessions of chemo, then patient will be shifted to a maintenance protocol. So same thing with urothelial cancers. These are advanced stages. After giving a few sessions of chemotherapy and the patient is stable, then they're trying to see if maintenance immunotherapy will increase survival of these patients. So this is a very important slide. You can forget all my slides and just remember this one. This is the current standard of care for muscle-invasive bladder cancer and metastatic urothelial cancers, 2020. Okay? In neoadjuvant setting, if the patient is cisplatin eligible, then the preferred choice is still chemotherapy using dose-dense MVAC. And alternatively, you can give your checkpoint inhibitor on a clinical trial setting. Remember that, on a clinical trial setting. For cisplatin ineligible, then we offer upfront surgery, then consider adjuvant trial. For first-line metastatic disease, cisplatin eligible, then the preferred first line is your double, again, dose-dense MVAC. Alternatively, you can give gemcitabine or cisplatin. For those patients who are cisplatin ineligible and we don't know the status of your PDL1 or negative PDL1, then the preferred choice is carboplatin and gemcitabine. And then alternatively, you can use gemcite as single agent. And for some patients who are very unfit to undergo any form of chemo, then you may use pembro or atezolizumab. But with this one, it's very interesting. No? Cisplatin ineligible, but based on the tissue markers, based on the immunohistochemistry, the patient is PDL1 positive, high score, then the preferred treatment is not chemo, but the preferred treatment is use of your immunotherapy, pembrolizumab or atezolizumab. So in conclusion, the results of your immunotherapy treatment in muscle-invasive metastatic bladder cancer is very encouraging. They have very good response rates. Cisplatin-based chemotherapy remains a standard of care for those patients who are cisplatin eligible. And of course, we may use single-agent atezolizumab or pembro in a cisplatin ineligible patient, especially if the PDL1 score is high. Of course, it's FDA approved already. The first line and second line treatment of advanced urothelial cancer, you may use the PD1 or PDL1 inhibitors. So we have a lot of ongoing clinical trials with the use of your immunotherapy in neoadjuvant, adjuvant, or maintenance setting. But we still have a lot of things to consider and look into with regards to combination and sequencing of our immunotherapy. The role of dual immunotherapy for our patients, the role of chemoimmunotherapy, and of course, a combination of immunotherapy and radiation therapy. I think this is my last slide. Thank you very much.
Thank you very much, Dr. Querol. So we have seen, given the two lectures, that at this time, especially during this time of the pandemic, despite the limitations such as that posed by the worldwide shortage of BCG, with the advent of immunotherapy, especially in the treatment of bladder cancer patients, we are given a new ammunition or a new weapon by which we will be able to help our patients with bladder cancer, especially those with muscle-invasive disease and metastatic disease. So with that, I would like to proceed to our interactive session for urothelial cancer. We will be having again our speakers, Dr. De Guzman and Dr. Querol. But joining us would be Dr. Brian Cabral, who is a transplant nephrologist. He is a consultant in the Asian Hospital Medical Center, Makati Medical Center, and St. Luke's Medical Center Global City. And he's also a clinical associate professor in the Philippine General Hospital. Welcome, Brian.
Thanks for having me, Lauren.
Okay, so I will now proceed in presenting the case. So for our case, we have a 60-year-old male who underwent kidney transplant, living-related donor in 2005. And the patient is currently on mycophenolate mofetil, cyclosporine, and prednisone. And the patient has been complaining of gross hematuria for 10 days. KUB ultrasound showed a 2.3 by 1.8 centimeter mass on the right lateral wall. And the graft ultrasound was unremarkable. Next slide, please. So the patient underwent cystoscopy, transurethral resection of bladder tumor, examination under anesthesia in July 2019. And histopath results showed high-grade urothelial carcinoma, no muscle invasion seen, no lymphovascular invasion seen. Next slide, please. Okay, so given this patient, what would you do next? Or what treatment would you opt for? Our poll is up. You can now key in your answers. Okay. All right. So, majority answered intravesical combination chemotherapy, gemcitabine plus docetaxel. And the next answer was quite far. So the leading answer was the combination chemotherapy. First of all, given our case, I would like to ask Dr. Cabral, given our patient who's post-transplant and who developed bladder cancer, the question that comes to mind would be, do transplant patients who are usually on immunosuppressive therapy carry a higher risk for developing cancer?
Definitely they carry a higher risk. In fact, depending on, there's a lot of information that would have been nice to have. What induction therapy did this patient actually receive? What were the levels of this patient's immunosuppressants? Were there any changes, etc.? All of these can contribute to provide an additive effect in increasing the chances of cancer or malignancy in patients who are post-transplant. So unfortunately, it's really just something we have to deal with and accept once a patient receives a kidney transplant or any type of solid organ transplant, that their chances of malignancy are actually increased.
Okay, thank you very much. Are there, given the immunosuppressants of this patient, are there particular immunosuppressants which put a transplant patient at a higher risk? Is there such a thing?
Well, if going back to what we discussed about induction therapy, so basically for solid organ transplants, we have two choices. Well, three, if you're going to do pulse steroids alone, or you could do a combination of pulse steroids with an IL-2 receptor antagonist like basiliximab, or what's actually the most common is the one where we use thymo or thymoglobulin, which is a lymphocyte depleting agent. Considering all three, I would say that the use of thymoglobulin probably increases the risk of malignancy in these patients the most. Again, that depends on the dose and the subsequent maintenance immunosuppressive therapy that these patients are going to be taking.
Okay. So, given our poll question, I would like now to direct the question to Dr. De Guzman. In terms of reducing the risk of disease recurrence and progression, how would you compare the three options given?
Well, I'm actually very happy, to be honest, Norman. I'm very happy with the poll turnout. So yeah, this is the best option for me, the combination or sequential chemotherapy, gemcitabine and docetaxel. That will give you the best numbers in terms of reduction of recurrences in about 2 years. So that's the best you can hope for, recurrence-free survival in about 2 years. So with the gemcitabine plus docetaxel, it will be about 65% or a bit higher than that. And that's the best you can hope for in this scenario. Now, being a transplant patient, I would go for that option automatically, the best option possible, because you know that it's just a matter of time before recurrences will come if you don't give anything.
Okay. So I remember you mentioning a while ago that for high-risk disease, that is where the benefit of combination therapy would come in as compared to single agents. Is that correct?
Okay, if you want to use it for high-risk disease, it's a bit controversial. So for high-risk disease, BCG is still the best. Mm-hmm. But for a transplant patient, that's not something I would ever consider giving for a transplant patient BCG.
Or in the absence of BCG.
The absence of BCG, this would be your best bet. So combination sequential chemotherapy, or if you want to try it, chemohyperthermia, although that's still not mainstream yet. So I'm a bit hesitant to recommend that. So I would go for gemcitabine and docetaxel. And you can give that in an outpatient setting. The patient will be less prone to infections that way.
Yeah, just a point of clarification. You have mentioned several times in your lecture recurrence-free survival. But when it comes to the risk for progression, can we even talk about that when we're talking about intravesical chemotherapy?
No, we can't even talk about that even for BCG. Now, indirectly, you can make an argument that by decreasing the number of recurrences or the incidence of recurrences, you're thereby decreasing the chances of progression, but there is no evidence to support that whatsoever. So it really depends on your baseline tumor. If you start off with a very high grade tumor, your chances of progression are higher. So in that scenario, your best bet would be using the EORTC calculator and looking at those factors to determine your risk of progression. Now, if you give BCG or intravesical chemo, you won't be decreasing it significantly, the chances of progression. So again, that's why the option of early cystectomy will always be there if you start off with high risk tumors, because you know that it's just a matter of time before those tumors will progress.
Okay. So I will proceed with our case. Next slide, please. Next slide, please. Okay, so the patient opted for observation and he underwent surveillance cystoscopy, which was performed in October 2019 and January 2020. And there were no recurrences noted. But 7 months after TURBT, gross hematuria was again noted. At that point in time, creatinine was 3.1. And KUB ultrasound showed graft hydronephrosis with urinary bladder wall thickening on the right. So for that, because of that, the patient underwent graft nephrostomy tube insertion. These are the laboratory results of the patient at that point in time. CBC and creatinine. If you would note, creatinine for the past 15 years ranged from 3 to 3.5. Present creatinine is 3.1. Next slide, please. This is the FDG PET scan, which shows the graft with the nephrostomy tube in place. Next slide. Okay, so here we see the hypermetabolic focus on the right lateral urinary bladder wall, likely obstructing the graft ureter. Next slide, please. And on whole body scan, there was no evidence of metastasis. Next slide. Okay, so given all of those findings, tumor on the right lateral wall, the patient underwent cystoscopy, transurethral resection of bladder tumor, and examination under anesthesia. Intraoperatively, there was note of 2-centimeter papillary mass in the right anterolateral wall, moderate trabeculations in the bladder, and the bladder was mobile on examination under anesthesia. Histopath results showed a high-grade urothelial carcinoma with evidence of muscle invasion, and it was also positive for lymphovascular invasion. Next slide. So given these findings, what would be your management plan for the patient at this point? So choices are immunotherapy with pembrolizumab, neoadjuvant chemo and radical cystectomy with native and graft nephrectomy and ureterectomy, radical cystectomy with ileal conduit, and trimodal therapy. Okay, so our results are up. Majority would prefer proceeding with radical cystectomy with ileal conduit. Okay. So let me ask Dr. De Guzman, what would you recommend for this patient?
Well, I agree with the poll again. I would go straight with a cystectomy. I won't even consider giving neoadjuvant chemotherapy for this patient given his condition. I'd go straight out for a cystectomy. His creatinine is a bit high. I hope we're able to at least preserve that with an ileal conduit, and of course limit the number of infections post-op. That'll be my plan.
Okay. Next slide, please. Next slide, please. So the patient underwent radical cystectomy and left pelvic lymph node dissection, native ureterectomy with ileal conduit. Histopath results showed invasive micropapillary urothelial carcinoma, WHO grade 3 with extension into the perivesical fat, positive for lymphovascular invasion, and 1 out of 6 left pelvic lymph nodes positive for tumor. Next slide. So at this point, what would be the best option for this patient? Let's put the poll up. Okay, results please. Okay, so close answers, adjuvant chemo, adjuvant immuno, observation, and close follow-up. So let's ask Dr. Querol what he would recommend for this patient.
Yeah, with this kind of patient with a high creatinine post-transplant, so adjuvant chemotherapy patient might not tolerate the side effects of this. Of course, the indication for adjuvant chemo is for T3, like this one, perivesical and node positive. But because of the condition of the patient, is not fit to undergo adjuvant chemotherapy. The use of GemCarb, less toxic for adjuvant chemo, like cisplatin. Most of the trials approved are in the metastatic setting. So you can use GemCarb if it's a metastatic setting. For adjuvant immunotherapy, remember the slides that I showed you, most of the indication right now is for metastatic, first line and second line. And there's a lot of clinical trials ongoing for immunotherapy, incorporating it neoadjuvant. But right now, we don't have data on giving adjuvant immunotherapy. So I guess I agree with the poll, observation and close follow-up for this patient.
Okay, thank you, Dr. Querol. All right, so we have been behind schedule for some time now. So we're sorry to cut short this panel discussion to give way for our next scheduled session. Thank you very much to our panelists. It's unfortunate that we have limited time to discuss this very interesting case, but thank you very much to our attendees for this session. Thank you. So let me just hand over the floor to Dr.